Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Axome. Difficult to treat hypertension has long been accepted as a reason to order a sleep study. We have faith that treating sleep apnea also helps treat high blood pressure. Does the way we treat sleep apnea matter? Is a residual AHI under 5 the only metric we should focus on when we decide that someone's sleep apnea is well controlled? Are there some tweaks we can make in our standard practice to ultimately improve the health of our patients more than we currently do? Dr. Abhishek Goyal is professor and head of respiratory medicine in Dehradoon, India. He completed sleep training in the US. He then developed a sleep medicine program at his home institution and has been studying the effects of PAP therapy on ambulatory blood pressure. His colleague, Dr. Prakhar Agarwal, is a pulmonologist in private practice in Bhopal, India. They recently published a paper on the impact of fixed CPAP versus auto-titrating CPAP on blood pressure and autonomic response. They are joining us today from India. Welcome. We're glad you could be here today.
Thank you, Dr. Seema, for having us on your podcast.
So you published a paper comparing the impact of APAP versus fixed pressure CPAP on blood pressure. So this builds on work that was previously done by Dr. Pepin and others around the world examining this exact thing. I found a paper from Portugal in 2021, and they looked at this from an economic standpoint since APAP is more expensive than CPAP in their country. Abhishek, was this a motivator for you as well?
So, Seema, during my residency, I was trained to do manual titration. So that was the only way I knew about how to treat these patients of sleep apnea. So when I started my sleep center at my previous institution, so I continued that practice. Around the same time, auto-PAP also was being promoted by ASM and other guidelines were also promoting APAP to be equivalent to fixed PAP. And some guidelines or some papers were also recommending that APAP was probably better than fixed PAP. But around the world, there were few papers which was suggesting otherwise. Like the first paper I could get hold of was in 2007, published in Chest. Petruno group from Italy showed that fixed PAP was better as far as blood pressure control was concerned as compared to auto-PAP. They had a small sample size of 32. Again, their group in 2014 again showed that fixed PAP was better than auto-PAP in control of sympathetic activity by cardiorespiratory coupling. In 2016, Pepin group from Grenoble replicated this study by using a large sample size of 322 individuals. So they also did compare the auto-PAP versus fixed PAP, but they used P95 of auto-PAP. And their primary objectives were not met, but they found that 24-hour diastolic blood pressure control was better with fixed PAP. So there was some indication that probably auto-PAP is not superior to fixed PAP. And that's why we planned the study to compare these two modes.
And when you're talking about auto-PAP, do you mean wide open 4 to 20, or was this more of a narrow range?
I think this we use it as an open range 4 to 20 auto-PAP.
So tell me about your research.
So we modeled this research on the existing literature, which I just mentioned about on the basis of Petruno and Pepin papers. So we try to understand why it worked better in Petruno paper from Italy and not to that extent in the Pepin et al. Paper from Grenoble. Yeah. So the only difference I could understand was the way they used their fixed PAP. So the Pepin group used P95 from auto-PAP titration for 2 weeks. So basically they gave auto-PAP for 2 weeks, and on the basis of P95, they used that as a fixed PAP. Whereas the Petruno et al., what they did was they did a manual titration. So that was the only difference. So I was clear that we have to do manual titration, and that was the only way we used to treat patients in our center. So
yeah, that's interesting. That's interesting, right? Because you're right, that is the difference. That makes more sense to me.
Yes. And the second difference in our study that was we took only OSA patients with hypertension, because we were clear that we want to see the difference in hypertension. So the study from Pepin et al. From Grenoble, they took 65% of the hypertensive individuals in their study group. So we took only patients with hypertension, only OSA, moderate to severe with hypertension. And the
Okay.
third and the most important difference was the crossover study. Because initially I thought that probably some patient will respond to fixed PAP more, some will respond to auto PAP more. So my idea was to find out which patient will improve with auto PAP and which will improve with fixed PAP. So that's why I tried to do a crossover study to find out which patient will improve with which mode.
Tell me a little bit more about the crossover.
So basically, people were randomized to receive a fixed PAP or auto PAP on the same machine. So we used S9 resped machine,
Mm.
and the machine looked outside the same from the outside, but the algorithm was different. So patient did not know which mode they were on. So we gave the machine to the patient. By randomization, they were either put on fixed or auto, and after 2 weeks of after 4 weeks of using in the first arm, they were given a washout period of 2 weeks, and then they were again shifted to other arm. So in the way, same patient was given both the treatment, fixed and auto.
So, Prakhar, how did you assess blood pressure?
So we assess blood pressure through ambulatory blood pressure monitoring. This ambulatory blood pressure monitoring was done 4 times. It was done during the start of the enrollment. So when the hypertensive OSA patients were enrolled, we did a baseline ambulatory blood pressure monitoring. In our ambulatory blood pressure monitoring, we recorded BP every 15 minutes in the daytime and every 30 minutes in the nighttime. So after getting the first reading of ambulatory blood pressure monitoring, the patients were randomized to either fixed PAP or auto PAP, and they received the respected PAP modality for 1 month. After completion of 1 month of the first PAP therapy, again ambulatory blood pressure monitoring was done. Then a washout period of 2 weeks was given. After the washout period, again ambulatory blood pressure monitoring was done. Then the patients were crossed over to the other PAP therapy. Those who received the fixed PAP in the first arm now received the auto PAP, and those who received the auto PAP now receive the fixed PAP. And after completion of the 1 month of the other PAP therapy, again ambulatory blood pressure monitoring was done. So it was done for total 4 times.
Oh, wow. Okay. And so then, because it's 24 hours, you could look at daytime plus also dipping at night.
Yes. So we recorded the 24 hours systolic blood pressure, 24 hours diastolic blood pressure. We recorded the daytime systolic and the diastolic blood pressure, the nighttime systolic diastolic blood pressure, and also the dipping in the systolic blood pressure and the diastolic blood pressure.
So, were these patients on medications or were they uncontrolled hypertension?
So the since this was a crossover trial, so patients who were on hypertensive medicines, they were asked not to change their hypertensive medicines. And those who changed their hypertensive medicines, they were excluded from the study.
I see. Okay.
So can I add, some of these patients were on antihypertensives, but they didn't change their medicines.
Okay. So, because this was 24-hour, then could you assess dipping?
Yes, we made sure to assess the dipping pattern because in USA we know that nighttime blood pressure is especially important because a lot of sympathetic activation and cardiovascular stress occurs during sleep. And moreover, nighttime blood pressure is a stronger predictor of cardiovascular outcome and also the nighttime dipping patterns. So we made sure to capture the nighttime dipping patterns, and that's how that was another indicator in our study so that we can see what are the cardiovascular outcomes in both PAP
Mm.
modalities.
So, how did you assess autonomic response?
For autonomic function test, we first we performed the short-term heart rate variability analysis using a 5-minute ECG-based HRV protocol, and also we did the Ewing battery for autonomic testing. So in this, we evaluated the frequency domain parameters like LF ratio, HF ratio, LF HF, and the LF HF ratio, and also the time domain parameters such as RMSSD and PNN50. Secondly, the nocturnal dipping patterns on ABPM, they also indicate about the autonomic response. So this was also captured. So this is how we measured the autonomic response.
So, it was via measurements you were already capturing with your 24-hour ambulatory blood pressure monitoring, or did you have an additional device?
So we had an additional device for autonomic
Mm,
function test, and 24-hour ambulatory blood pressure monitoring only helped us to capture the dipping part of the autonomic response.
okay, that makes sense. So, how big a study was this? How many subjects were recruited?
We screened around 150 patients, and finally we randomized 46 patients with moderate to severe OSA and hypertension. In the first arm, after the first arm, there were 16 dropouts, and dropouts were mainly because of the PAP non-compliance or those who changed their antihypertensive medications. In the second arm, there were no dropouts. So 30 patients completed both treatment arms, and they were included in the final analysis.
Okay. So, you said moderate to severe. How severe was the sleep apnea? What was the average AHI?
Our cohort was a fairly severe OSA one. So the median AHI in our cohort was 59, and the mean
Wow.
BMI was around 29.7. Yes.
Okay. Wow. So, what were your primary endpoints for this study?
We had two primary endpoints, and the first was the change in 24-hour ambulatory blood pressure parameters, and the second was the change in autonomic parameters, the mainly the LF, HF, and the LF-HF ratio.
Tell me more about that. What does that mean, LF and HF?
So basically, it is low frequency and high frequencies. And low frequency, high frequency ratio is basically how well your sympathetic control is. So in most of the patients of OSA, LF and LF is basically a response of sympathetic activity, and HF is basically response of parasympathetic activity. And ratio is deranged in the cases of whenever there is an autonomic abnormality. So this is the
Okay.
easiest method, which is replicable and which is usually done in most of the autonomic studies.
Okay. So, were there any secondary endpoints?
Yes, we also assess several secondary endpoints, such as in the both PAP modalities, we compared the Epworth Sleepiness Scale for the daytime somnolence. We also compared the PSQI, which is the Pittsburgh Sleep Quality Index, to look for the subjective sleep quality, the Fatigue Severity Scale. We measured the PAP comfort and the PAP preference in both the arms, and also the nocturnal BP dipping status, which was a secondary endpoint.
Okay. So, was adherence similar with APAP and fixed PAP?
Yes, it was similar, and we we saw the adherence by seeing that how many patients use the PAP therapy for more than 70% of the days in the last 30-day period, and for more than 4 hours. So it was similar in both the groups.
Okay. What was the usage on average? How many hours?
So the usage in overall was average usage in the auto group was around 5.8 hours,
Oh,
the mean
wow.
usage, and for the fixed group it was 5.4 hours. So the usage was slightly, I will say, on the higher side towards auto,
Yeah.
and also the number of days used more than 4 hours was 81.3% the mean usage, and in auto group, and it was 78% in the fixed group. So it was also slightly on a higher side in the auto group. But interestingly, what we found was the residual AHI was similar in both the groups. The leakage was similar. The patient satisfaction score from the CPAP perception questionnaire was also similar. Another important thing was that we also checked the Epworth Sleepiness Scale, PSQI, fatigue severity scale, apart from this CPAP questionnaire for comfort, and all the parameters was similar in both the arms. So patient felt same with the both the therapies. Their sleepiness was same, their sleep quality, their fatigue severity was similar in both the arms. So patient did not know which mode they were better, because the patient perception was also almost similar in these group, but the difference was in terms of hypertension control. We found that fixed pap decreased systolic blood pressure significantly more than auto pap, and I think that is the major objective of giving any pap therapy to a patient.
Yeah, and so did you see that you went from a non-dipper to a dipper? And was that different in the two arms?
Yes, so we also did a post hoc analysis in response to a letter which we recently got. So
Okay.
we categorized the subgroup, the group on the basis of as systolic blood pressure dippers. So out of 30, 23 were non-dippers and 7 were dippers. So what was interesting was that in the non-dippers, fixed PAP and both auto PAP improved blood pressure, but fixed PAP had better blood pressure control than auto PAP. Whereas for dippers, fixed PAP improved both systolic blood pressure and diastolic blood pressure, but auto PAP worsened both systolic and
Oh, no way.
diastolic during night. So for dippers, probably auto PAP worsens blood pressure control. But as I mentioned, this was a post hoc analysis and the sample size was only 7 and it was not powered for this kind of analysis.
Yeah, that's fair. Yeah.
But I think we are adding to the evidence because previous study, one from Spain and another from China, both have shown that blood pressure improves in non-dippers and it doesn't improves in dippers. So probably in both the studies, autopap was used. So probably that was the reason why in dippers the blood pressure was not improving. PAP treatment, I think, needs more precision therapy rather than using a same auto PAP device to all the patients. So whenever we are doing a manual titration, we know about the position therapy, we know about the mask, about the right mode, about the right pressure of the patient. So which is very difficult to know if you are prescribing auto PAP to a patient at his or her home.
But it's interesting, right? What I was kind of wondering is, did you convert a non-dipper to a dipper? But it sounds like almost the opposite happened, that a dipper became less of a dipper on APAP versus fixed PAP?
So the chances of becoming a dipper from a non-dipper was significantly more in case of fixed PAP. But the
Okay.
chances of becoming remaining a non-dipper was higher in auto PAP.
Okay, so let's take a short break. And when we come back, we'll talk more about fixed CPAP versus auto-titrating CPAP and its impact on blood pressure and autonomic response. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking about fixed PAP versus auto PAP for sleep apnea and blood pressure. So, Abhishek, has this changed your practice?
So, Siva, I am an old school physician. I believe in proper full examination of the patient.
Yeah.
So, for me as a sleep physician, doing a level 1 PSG is like doing a proper full examination of the patient.
Yeah.
So, because you have so much data to look into, you can phenotype the patient now. You know not only about the AHI, not only about the T90 or OGI, which we can also guess from the HSAT, but we also know whether the patient has a specific phenotype, whether he or she has a low arousal threshold. We can know about the high loop gain, and more importantly, we can give the right pressure to that particular patient, and we can also use this right mask. I think level 3 studies followed by autopap is like telemedicine. That feeling of seeing the patient, the touching patient is not there. So you are guessing a lot of things. Patient sleepiness will improve as we have seen in the study. They will feel better. But whether their cardiovascular complications are getting better, that is, I think, the most common objective of giving CPAP to any particular patient. And we are not sure because studies have shown that PAP devices are better, but their studies have been equivocal. So I'm not saying that I am against technology, I'm against auto PAP. I think auto PAP is going to improve further, but I have serious doubt that auto PAP is going to be better than fixed PAP.
Well, but it's interesting, right? Because it's either broad, wide range auto PAP versus fixed PAP, but what about narrow range, like 9 to 12?
So I think narrow range auto PAP will be just like a fixed PAP, but for using a narrow PAP, you should know about which range you have to use. So you are talking about 9 to 12. You don't know whether 9 to 12 is better or 12 to 14 is better. So I think on that aspect, we need a manual titration. That's what I feel.
So, and it's funny, right? Because what I'm hearing, so I'm guessing the model in India is level 1 study, manual titration. Is that the
No.
model?
No, 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 no.
Oh, it's not. Tell me.
No, no, it's not. So most places in India are doing level 3 sleep testing.
Oh, they
And
are.
unfortunately, most of the times, these level 3 home sleep testing is auto scored and not cross checked by any sleep physician. So, on the basis of these reports, patients are prescribed AutoPAP.
Okay.
And very few centers in India are actually doing manual titration. Both of us at our respective centers are doing polysomnography and manual titration.
Oh, that's interesting. Okay. So you're hitting on something really important. When HSAT was first adopted, it was because the question had changed. So, meaning the question before was, is a home sleep apnea test as good as an in lab polysomnography? And the answer was no. But then when they looked and changed the question of, is a home sleep apnea test good enough to diagnose obstructive sleep apnea in a straightforward patient, right?
Right,
That
right.
sort of change in perspective changed what we do, right? And so I think that it sounds like you really take advantage of having additional signals, right? You mentioned arousal, and phenotyping. And so I feel like a lot of our care in the US is very much driven by insurance. And it is harder and harder for us to get a level 1 study for, especially for straightforward obstructive sleep apnea. And so then we try to do the best we can with a home test. And you're right, that often does fall down to AutoPAP. But then what I'm wondering is, the follow up is, I think most of us try to narrow the range and then narrow the range and then narrow the range, right? To your comment of how do you know 9 to 12 versus 12 to 15? I think because most people start at 4 to 20 and you look and you talk to the patient and then you narrow it, guided by the 95th percentile pressure.
Okay.
So what I'm wondering is, has that narrow APAP ever been tested or compared to fixed PAP?
There are very few studies which have compared AutoPAP versus fixed PAP. So most of the studies which I have mentioned about, they use an open range of AutoPAP.
Okay.
But I think why US and Europe is basically using promoting HSAT and APAP is, I think it is because of the cost issue with the level 1 polysomnography followed by a manual titration.
Sure. Well, and even access to care, right? There's
Yes.
how many people that have sleep apnea. So, in medicine, I think sometimes we have to embrace that perfection is the enemy of good. But it sounds like we also can, make a point of being more thoughtful in what we're doing in terms of the pressure settings.
Yes,
And our
because
follow-up.
the study you were mentioning about from the Portugal. So they in their country, what the model is that the AutoPAP is given on rental basis, just like a fixed PAP, but the rent of AutoPAP is much higher than that of fixed PAP. So
Okay.
that's why in their paper they found that the cost effectiveness of AutoPAP was less than that of a fixed PAP.
Okay. Is that the same where you are?
No, in India, the rental models are not very much different as far as fixed PAP and auto PAP is concerned, but the difference is in terms of the cost of the machine. In India, auto PAP, the cost varies from $500 to $800.
Okay.
Whereas fixed pressure machine, the cost varies from 300 to 350 dollars. So the
Okay.
cost is basically the difference in auto PAP and fixed PAP.
Yeah.
And
Yeah.
interestingly, in India, the cost of home sleep testing varies from 30 to $50, but a level 1 polysomnography, the cost varies from $120 to $150. So the difference
Oh.
in home sleep testing and level 1 polysomnography is not that high. The difference in US and Europe is the difference between a level 1 and level 3 is very high. I think the total cost of home sleep testing followed by AutoPAP, because you have to give AutoPAP after home sleep testing, the cost will be $550 to $850 in India.
Okay.
Compared to a level 1, if you do a split night study, the cost will be $450. The cost is lower in case of doing a manual titration during the same split night, which we do in our labs. And that's why I think blindly following the guidelines of other countries is detrimental, at least in our settings.
So that's interesting. So a split night study plus fixed PAP is less expensive than a level 3 with auto PAP.
Yes, at least in India.
Okay. Okay. Is there a lot of sleep apnea in India?
Yes, there are many patients, a lot of patients. So previous studies from India, which used older scoring rules, they had their methodological limitations. They
Okay.
found the prevalence of OSA, which was defined as AHI more than 5, in the range of 13 to 19%. But of late, we found that studies done all over the world, the most important, the landmark study of hypnoloss study by Professor Raphael Heinzer, this group found that the prevalence of OSA, which was more than 5, when they defined OSA as more than 5, the prevalence was 72% in the general population aged between 40 to 80 years. And when they defined AHI more than 15 as moderate and severe OSA, they found that every second male and every fourth female had moderate to severe OSA in general population. So this was the first study which showed that OSA is significantly more prominent and more prevalent than what we knew earlier about. Similarly, other studies like SHIP trend study from Germany, the BESA study from Republic of Benin, Africa, have shown very high prevalence of OSA in the general population. So on the same lines, our group also did a level 1 polysomnography in 1015 healthy volunteers, and we found that OSA, that moderate to severe OSA defined by AHI more than 15, was seen in 30.6% of the individuals.
Oh,
So
wow.
every third male and every fourth female in the age group of 18 to 80 had moderate to severe OSA.
That's
So it is
huge.
very, very high. The prevalence is very high. So I think the difference is the definition, because if you
Yeah.
define AHI more than 5 as OSA, I think everyone is suffering from OSA. So
Mm.
I think the definition of OSA needs to be looked into again.
So, and you're right, those numbers are extremely high. Is it craniofacial structure more than obesity, do you think, that drives it in India?
Yes, because in spite of having a Indian population is younger and thinner as compared to the European population,
Mm.
so we had a higher OSA prevalence. So what we did was we compared our group from India, the general population study group. We compared it with the hypnoloss study from Switzerland and the BESA study from Republic of Benin. So
Mm.
that was a large general population study of around 5,000 individuals from the general population. We found that at a similar level of BMI, Indians had higher waist and neck fat deposition, and
Mm.
Indians had higher Malampati scores. So probably due to this, Indians had more severe OSA at similar levels of BMI. More importantly, if an Indian develop OSA, his chances of developing hypertension, diabetes, and metabolic syndrome, the odds ratio was higher than a Swiss developing OSA or a Beninese developing OSA.
Huh.
Yes, another also important thing was that we also compared COMISA in these three population cohorts. We found that if Indians and Swiss, if they developed COMISA, had higher chances of developing hypertension and metabolic syndrome compared to the African population from Benin. We also found that in spite of having similar median AHI in the general population, Indian had a lower ODI than Swiss. So probably we have slightly higher arousal index than Swiss population
Mm.
that needs to be looked into.
Okay, but you said lower ODI, meaning like they desaturated more or
No,
less?
that means they desaturated less.
Less. That's what I thought. So then it's interesting that they have more of the metabolic, right? The hypertension and the diabetes. It's interesting, even though they're not as hypoxic.
So probably sympathetic activity plays more role in this population. That is
Mm.
just a hypothesis which needs to be proven.
Okay. So, Prakhar, I've been meaning to ask you. So, when you looked at the two studies, fixed PAP and APAP, did you compare the manual pressure versus the 95th percentile pressure? Like, were they the same or different? I'm
Yes,
guessing.
we do compare that, and they were
Yeah.
actually significantly different. So when our manual titrated pressure was compared with the 95th percentile of the APAC pressure, so it was around 2 centimeter of H2O higher than that of the fixed pressure was 2 centimeter higher than that of the average APAP pressure. So
Mm.
why, see, many clinics, like we discussed, many clinicians derive the fixed CPAP pressure simply from the APAP 95th percentile, but
Right.
our findings suggest that this may not be physiologically equivalent. We know that in APAP there's a pressure decay after periods of stability, whereas in manually titrated pressure there's a stable pneumatic splint throughout the sleep. And in our
Mm.
study, the manually titrated pressures were consistently higher than the APAP pressures, and that difference is correlated with the better blood pressure outcomes.
Yeah.
So while APAP may normalize the AHI, it may
Right.
not completely eliminate the flow limitation or subtle respiratory instability, and that may contribute to more sympathetic surges and lesser blood pressure control as compared to the fixed PAP.
But and the residual AHI though was similar.
Yes,
Yes, the residual AHI was
it
similar.
was 1.4
So
in both
that's
arms.
so interesting to me, right? Because how, right, if the AHI is similar, then I think intuitively as a clinician, you wouldn't think that you would need to go up on the pressure by 2 centimeters of water.
Yes, because the AHI of a download machine, the AHI from the download machine does not give you the complete picture,
Yeah.
because you don't know about the EG, you don't know about the cortical activity which is going on, cortisol activity which is going on in the body, and you don't know about the hypoxemia. It is basically measuring the flow, and it is not foolproof. The
Mm.
machines do not exactly measure the AHI correctly, because it has been shown in multiple studies that the accuracy of the download data from AHI of the download device of the devices is around 50 to 60%. So
Yeah.
it's not foolproof.
Well, and it's interesting, right? You used a ResMed S9, and I wonder if it would be different with an S10 or now S11.
I think the machines are getting better. I think machines are getting better. So
Yeah.
probably the results would be slightly more in favor of fixed PAP as in compared to the difference we saw in the S9. But still, I think with the even with the advancement of the machines, fixed PAP will probably work better than auto PAP, because some patient might require a higher pressures which remains should be remain stable. Because what happens with auto PAP algorithm is, if the patient is doesn't have any apnea or hypopnea, the machine doesn't detect any event, then after some time the pressure is bound to decrease according to
Yeah.
algorithm. So after that decrease in pressure, probably there is going to be increase in cortical activity, there is going to be an arousal or a hypoxemia. So that will lead to more similar activity, and probably that is the reason of increased blood pressure seen in the autopap arm in the dippers.
Mm. And you raise a really important point about the algorithm, because even from brand to brand, the algorithm is different.
Even within brand, even for the ResMed, we have three models of AutoPAP, at least in India.
Oh, wow.
Yes, there is AirSense. There is, I think, the other name for AirStart, and probably the third
Yes,
is
start
AirStart for her.
Oh,
So there are
yeah, that's
three
true for
auto
her. Yeah.
CPAP models in India, and all these models have different algorithms.
in different cost.
Yes,
Different cost, really?
yes,
Okay, so it's definitely a different world, because in at least in my region, I think everybody who gets a CPAP gets an AirSense either for her or whatever, but they're all capable of APAP. And then you just convert it to a fixed PAP without changing the machine. At least where I am.
most of the places in India also do the same. They do a level 3 home sleep testing.
Yeah.
They prescribe a auto CPAP.
Yeah.
They prescribe auto CPAP, but it is up to the patient from where he has to purchase, because it is out of pocket expense for most of the patient. So what is happening right now in India is patients are purchasing CPAP machines, whatever is more cost effective to them, and what is cost effective may not be even that accurate, because a machine which is not that good as a ResMed or a Philips or a Fisher Paykel may not
Mm,
work as good as what they are doing. But we have compared the same model
yeah.
with different modes. Even then there was difference. So if you compare different brands, the difference is going to be huge
So can
in
they
terms
just
of blood pressure
purchase
control.
it by cash, or do you need to have a prescription, or do they see a sleep person?
So usually they are prescribed home sleep testing or level 1 polysomnography. After that, they are prescribed auto CPAP or CPAP, depending upon where they have done the sleep
Mm,
study. But after that, it is basically patient who has to purchase that machine in India at most of the places.
Okay. Huh. So it's a whole different world. Interesting. When my grandmother was sick in India, my mom went, and she had to go to the pharmacy, purchase the medication, bring it to the hospital so they could administer it to my grandma. So it
Yes,
was a
that
very,
happens
yeah,
in
it's a
some
different
places.
model.
It's
Yes.
very common. Eh?
Yeah. Okay. So is there something else I should have asked you?
So I think we have talked about most of the things which I think this paper meant about. But I think the important point is basically the craniofacial structure, which we discussed briefly, is different in our population compared to the population you are seeing.
Mm.
So I think each population has a different kind of OSA. That's what I believe. Every population has different severity of OSA. So whatever we are practicing in our setup, we should have our own guidelines and we should not blindly follow what other country is doing. That's what I feel.
That's a good point. So, Prakhar, let's start with you. Do you have a key takeaway for us?
The major take-home message is that not all PAP modes may be equivalent from the cardiovascular perspective. The central finding in our study was that FPAP guided manual titration was superior to auto-PAP for blood pressure control in hypertensive OSA patients. So even though our patients may feel equally satisfied or report similar relief, and even the machines may show similar residual AHI, their cardiovascular protection may not be equivalent. And for a patient with hypertension, we should uh, think of titrating it to a manual titration because then it has shown to have a better cardioprotective action as compared to the autopath.
Mm. Abhishek, what about you? Do you have a key takeaway for us?
So I think in our study, we have shown that fixed PAP works better for blood pressure control than auto-PAP. It leads to better systolic blood pressure, diastolic blood pressure control, leads to more dipping. So fixed PAP is a better mode as far as blood pressure control is there, as far as autonomic nervous system control is concerned. So people right now are the research is basically going in the direction of the personalized therapy for sleep apnea. So for different phenotypes, people are talking about hypoglossal nerve stimulation, mandibular advancement devices, sedatives. But I think we should also talk about the personalized PAP therapy because each mode in the same machine behave differently as far as blood pressure control was concerned. If we talk about different algorithm of different manufacturer, I believe that the difference is going to be even higher if we use different mode in a same patient. So I think there should be standardization of the algorithms for PAP devices. And I think future studies will guide us regarding the personalized PAP therapy in patients with OSA.
That's true. That's a really good point. Well, thank you both for joining us today and helping us to better understand the nuances of fixed PAP versus auto PAP, and really for teaching us a little bit about how your practice differs from our practice in the US.
Thank you, Seema, for having us.
Thank you.
Thank you.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.